Hey guys, this is Dr. Charity Stanley, and today we are looking at oncology. So, for cancer, there's a couple of big things that you need to understand. The overview for cancer is that there is a problem with the genetics and there is a problem with the immune system. The genetics have to be in some way messed up. There's tons of different ways that that can happen, but the immune system also has to be messed up as well because if the immune system is working well, it will recognize these cancer cells and get rid of them. Okay. And so with the immune system will recognize these aberrant cells and go ahead and kill them or destroy them in different ways. So the cells actually change as a result of being a normal cell, that's our baseline, or being benign or being malignant. So there's some vocabulary you need to be aware of before we start out. So when cells start to atrophy, they shrink to a smaller size. So in situations where you have a cast, the muscles will actually shrink to a smaller size as a result of not being able to move from being in the cast. Hypertrophy is an increase in individual cell size. So sometimes we do this on purpose, and this would be a physiological increase, such as from exercise. However, in situations where you're not exercising, trying to get increase in muscle size, it can be pathological. So, for instance, we talked about left ventricular hypertrophy. That's where your left ventricle gets larger as a result of hypertension, then that would be an example of something that's pathological and that would not be something that you would want is left ventricular hypertrophy. Hyperplasia is an increased number of cells. So, for example, if you have scar tissue and you have what's called keloids, you make too many cells to try to repair the number of cells that were destroyed. Hypoplasia is fewer cells than what is normal for a given area. Now, anaplasia is really interesting because as cells grow and mature, they become very differentiated and they like to work on what they like to work on. And so kidney cells, they're kidney cells, they're going to work on kidney stuff. They're not going to try and be a neuron. A neuron's not going to try and be a kidney cell. And so what happens with anaplasia is the cells forget what they're supposed to be and what they're supposed to be doing, and they start to go backwards in their de-differentiation. So what that means is that the kidney cell starts to forget it's a kidney cell and then tries to do other types of cellular activity. And that's one of the key functions of metastasis. And so when the cancer metastasizes, then often these will be anaplasia cells that are moving to other parts of the body. Metaplasia, this is replacement of one cell type with another. For example, when we have a stomach acid that keeps coming up and burning the esophagus, that tissue is damaged and it's replaced with another type of tissue. Dysplasia is deranged cell growth. So we often hear of dysplasia within cervical cells, and they go in and they kill the cells that are growing aberrantly as a preventative for cancer. Neoplasia is going to be new cellular growth. Apoptosis is programmed cellular growth. Or I'm sorry, apoptosis is programmed cellular death. And so this is like the time clock when every cell is born, it has a certain amount of time that they generally live. and then it is destroyed. That programmed cellular death is called apoptosis. Euploidy means EU means good. Ploidy refers to chromosomes. If you have euploidy, then that's a complete set of chromosomes that are good. Here's a diagram talking about the different types of words that we just used. So hypoplasia is we have fewer number of cells than is deemed normal. And so hyperplasia, we have too many cells than is deemed normal. Neoplasia, we have new types of growth that are going within existing cells. Dysplasia, so this is a change in the shape, size, or organization of cells, deranged cell growth. And so the cells are starting to get bad, but they're not too bad yet. Metaplasia is a change in the cell type. Okay. And anaplasia is where they de-differentiate. They forget what they're supposed to do and they start running amok and causing problems. So there's several different factors that we're going to look at with the biology of normal cells. We have to know what's normal before we can figure out what's abnormal. And so with normal cells, they have a specific morphology. They have a specific job. They tend to have a smaller cytoplasm to nucleus ratio. Nucleus tends to be smaller because it's not working all the time for reproduction. We're going to see a difference in this with cancer cells. They tend to have a larger nucleus. And so the nucleus changes the cytoplasm ratio. Biology of normal cells, they tend to be differentiated and they do their own jobs. Tight adherence means they are bound tightly to the basement membrane. Non-migratory, they don't go places. A kidney cell is not just going to leave the kidney and decide to go hang out in the lungs. And in cancer cells, we see that. So cell growth is well regulated. When new cells are made, new cells are limited by several different factors so they don't overgrow or become troublemaker cells. Contact inhibition. This is where you don't want to, kind of like in elevators, you want equal distance among people in elevators. Contact inhibition is going to be you don't want, once the cell grows for its allotted area, you don't want it to grow bigger than its allotted area. So contact inhibition, when it runs into other cells, it will stop growing. Apoptosis, this is programmed cellular death, and euploidy that we just talked about. So this is some distinctive morphology of some normal cells. So cells can look different depending upon what their job function is. And remember, red blood cells, they have a lifespan of 120 days before apoptosis happens. Different malignant and benign cells. Benign cells tend to be normal cells. They tend to grow in the wrong place at the wrong time. So for examples of benign growths are going to be moles, fibroids, skin tags, nasal polyps. And so when something's benign, once we take it off, then it is unlikely to come back. Malignant cells are abnormal. They have no useful function, and their sole job is to cause trouble for other cells in the body. So our biology of benign tumor cells, these are going to be a specific morphology. They haven't de-differentiated. They're going to be a smaller nucleus because remember, again, they are still under the control of the body to stop growing at a certain point. They're still differentiated. They don't migrate. They grow orderly, and they have a normal amount of chromosomes. So in contrast, malignant cells, they become anaplastic, they have de-differentiated, and their goal is to cause problems in other tissues of the body. They have a larger nucleus because this nucleus is dividing all the time. And by this nucleus dividing all the time, it has a larger nuclear to cytoplasmic ratio. It loses functions and doesn't know what it's supposed to do, so instead it creates havoc. It's loosely adhered to the basement membrane. It likes to get into the blood or into the lymph nodes and go places. Contact inhibition. It loses all desire to have contact inhibition and it becomes very invasive with its cell growth and migration. There's very rapid and continuous cell division. It's not being turned off like it should. And your chromosomes are now abnormal when you have malignancy. Within anaplasia cell, the cancer cells no longer keep their appearance, and the cells, sorry about that, the cells tend to become smaller and they tend to be more mobile. And so with this, cancer cells like to navigate throughout the body and set up shop different places to be able to spread the cancer, spread the malignancy. Also has a larger nucleus. Remember that nucleus is regulating cell growth. Within cancer, cells are growing without regulation. And so it has a larger nucleus. Functionality, the cancer cells serve no purpose. The only thing cancer cells do is reproduce and grow for themselves. They do absolutely nothing for the body. Loose adherents, they like to break off and get into the bloodstream or the lymph nodes to be able to travel. So there's an old saying that good fences make good neighbors. And so contact inhibition is going to be having a fence around what is yours. And so just like the fence will help keep out strangers from invading your property, contact inhibition helps to stop other cells from invading and causing problems. Now, with the cancer and with malignant cells, contact inhibition no longer occurs. So, what this means is that the cells will start to invade neighboring cells. The cancerous cells invade the good neighboring cells, and it's hard to manage the disease because of this. Um, Movement to other organ systems that's right next to it. For instance, liver cancer can move to the lung, it can move to the esophagus that's right next to it. And so the disease becomes very, very hard to manage as a result of this. So with normal cells, they like to take up the same amount of room that they are allocated. Cancerous cells don't care about this and they like to clump up and glump up and they have no contact inhibitions, so they grow on top of each other and take up as much room as they like. So with cancerous cells, they do not regulate their reproduction. They do not turn off cellular reproduction. They continued in mitosis continuously. And the cells also do not respond to signals for them to be destroyed. So they no longer respond to signals for apoptosis. You also can have abnormal chromosomes and problems with the chromosomes. Chromosomes can be gained, they can be broken, they can be lost. And cancer cells may have something, they usually will have something wrong with the chromosomes. Remember, I talked about that you can have bad genes. Well, you can have very bad genes, like a family history of cancer. And so, if the immune system is good and is working appropriately, then that's not an issue. What will happen is the immune system will destroy those deranged cells that are continuing to grow. If your immune system doesn't recognize it, that's where we have problems, and that's where cancer continues to grow. So you can have a bunch of different chromosomal abnormalities. We're not going to be asking you to know specifics, but this kind of explains some of the whys on different chromosomal problems. Here's a table that really outlines the difference between normal cells, benign tumors, and malignant tumors. Benign tumors tend to have very delineated outlines around it. They tend to have a hard cellular surface that's covering the tumor. And so when they're taken out, when they're surgically removed, it's pretty easy to get it all. Now, once you remove a benign tumor, it is unlikely to come back. Malignant cells, once you cut in, it's not very clear differentiated boundary. And so with that, it's very likely that some of those cells may break off and may create problems elsewhere in the body. So here's some of the other words that you're going to need to know. Cellular regulation, this is what regulates everything that the cell does. Carcinogenesis, this is the development of a normal cell changing into a cancerous cell. Oncogenes. So oncogenes are cancer genes. So they are protected. These actual chromosomes are usually covered by something called a proto-oncogene. Proto-oncogenes will suppress cell growth that no longer responds to the regular genes telling it to stop dividing. Now, this can stop the oncogenes from causing the cancer. A proto-oncogene has to be damaged in some way, whether that be from environment, whether it be from tobacco use for 20 years, chronic alcohol consumption, laying in the sun, getting ultraviolet light and radiation, that it destroys the proto-oncogene, allowing the oncogene to run amok. Oncoviruses, this is going to be like HPV, different viruses that cause cancer. Metastatic tumors, these are secondary tumors, and this is where cancerous cells break off from the primary location and they move through the body and create new tumors. Ploidy is looking at the genetics and describing by chromosomal number and appearance. Carcinomas. So the way to remember how cancers are named, carcinomas are on the outside of the body and they're the innermost tube systems of the body. So anything that has an exit to the body is will be called a carcinoma. Okay. So your skin is on the outside. Your GI tract, oral pharyngeal cancers or carcinomas. Your GI tract, your esophagus opens to the outside, your colon opens to the outside. So anything within the GI tract is called a carcinoma. Your lungs take in air from the outside. The uterus is open to the outside through the cervix. And then the breast. Now think of it this way. They don't have a direct opening to the outside like these other organs. However, they do have openings to the outside that allows breastfeeding to occur. And so that's the easiest way to remember the words that you use. So carcinomas are anything on the outside or the innermost tube systems, anything that has openings. Sarcomas is going to be basically most of the other stuff. Sarcomas are going to be the stuff in between. Bone cancer, muscles, fat, cancers that happen within the lymph system. Adenocarcinomas they arise from glands. So adenocarcinoma would be like thyroid cancer. Leukemias are problems with the blood forming cells. Lymphomas arise from the lymph tissues. And multiple myeloma, this arises from the plasma cells that affect the bones. So here's a bunch of different ways of naming cancers and what the fancy medical terms are. So risk factors for cancer. The older you are, the weaker your immune system is. So it increases your risk for cancer. The older you are, the longer your chromosomes have been around. And so that also increases your risk for cancer. Your race, for some reason, we don't know, African Americans tend to have cancer hit earlier and they have higher mortality even with when treated with the same treatments, the conventional treatments. Genetic disposition, you can't choose your family, you can't choose the genes. Exposure to chemicals, viruses, tobacco, again, these destroy the proto-oncogenes and make it more likely that the bad genes will be expressed. Exposure to viruses, exposure to the sun, and basically the American diet. So high in red meat and high in fat and low in fiber. Okay, these are the most common cancers. Primary prevention. So there's things called primary prevention, secondary prevention, and tertiary prevention. Primary prevention is going to be treating the problem before it happens. Okay. So we want to stop the cancer before it ever happens. So, how do we do that? For skin cancer, we tell people to use skin protection. For lung cancer, we tell people to stop smoking. We adjust the lifestyle to decrease the risk factors. We can remove things that could potentially turn into cancer, such as moles. You've heard of Angelina Jolie. She found out she had the genetics for breast cancer. She was positive for BRCA1 and BRCA2. And so, preventatively, she actually had her breast and her uterus taken out. If it's not there, it can't become cancerous. And so removal of at-risk tissues. So with this, primary prevention can also be vaccines. So primary prevention, we're trying to push off the disease starting, okay? Secondary prevention, we want early recognition of the disease, early treatment, early identification. So secondary prevention would be things like mammography, colonoscopy, doing fecal testing, checking for blood within the stool, doing routine prostate screenings, doing screenings for genetic mutations, doing pap smears. And so all of these are secondary preventions. Tertiary prevention is going to be early care, and we want people, once they're diagnosed, to be able to live the best life that they can. Okay, so primary prevention, we're stopping the disease before it happens. Secondary, we're doing early screenings and early diagnosis. And tertiary, you've already got this disease. Now, how can we best improve your quality of life? There's several things that can affect malignant disease. How are you going to know if something's cancerous or not? You're going to be looking for things like weight loss that's unexplained, chronic fatigue, being in pain. So you're going to see changes in bowel or bladder habits, sores that don't heal, unusual bleeding or discharges from places that don't normally have discharges, thickening or lumps in the breast or elsewhere, indigestion, difficulty swallowing, changes in warts or moles, nagging cough or hoarseness. Now, cancer cells, they are kind of like parasites. And so what's going to happen is the cancer cells will try to create a vascular system. So it actually releases chemicals that creates blood vessels into the cancerous tumor. And so it takes the first fruits of the body. So basically, anything that the person eats, the cancer is going to fuel itself to grow from the calories that the person has eaten. Now, that doesn't leave enough for the rest of the body. And so they tend to be very emaciated, very, very tired all the time. They don't have energy because the cancer is literally taking the first fruits of the body and feeding itself first before it gives anything else to the rest of the body. So, how do we diagnose cancer? So, diagnosis of cancer, we do this several ways through imaging tests, biopsies, MRI scans, CAT scans, fluoroscopies, PET scans, and nuclear imaging. So, PET scans are really cool. PET scans, we radioactively label glucose. And what happens is I said that the cancer likes to feed itself first. So if it eats more glucose, then that's going to cause more radioactive marker to be dumped in that specific area. And so what we do is we put them under a camera to be able to recognize these nuclear isotopes, and they will actually glow brighter in these areas of high metabolism. So before this PET scan, you need to deprive the cancer of food. So you want to avoid carbs because that way it will have a more conclusive test because the cancer cell will be hungry and will eat more. And so high protein meals are highly encouraged. Need to be NPO except for water and meds about 6 hours prior to the test. So this is what I was talking about with how the tumors secrete um, chemicals that cause the blood vessels to actually grow into the tumor. And by growing into the tumor, it can actually feed itself first. Okay, now looking at how do we tell how bad cancer is? This is where we get into grading and staging, and that's where we tell exactly how severe that the cancer is. So, grading and staging mean two different things. Grading is we are looking at the cellular aspects of the cancer. We're looking at how dedifferentiated it is, how anaplastic the cell is. We're looking at how tightly it's bound to the basement membrane. Is it adhering to the contact inhibition rules? Staging looks at the clinical aspects of the cancer. And ploidy is looking at the structure and number of chromosomes to see how the chromosomes are looking. Some cancers are more malignant than others. So some cancers tend to be well differentiated, and these are ones that tend to grow slowly. Others, the cells have de-differentiated and they grow and spread rapidly. So grading is on a scale, and again, this is based off the histology of the cells. And so GX is the grade can't be determined, G1 through G4. G4 is the most serious. Now, staging, this is looking at our clinical implications. So the tumor node metastasis system is used. So what they're looking for is looking at the tumor itself to see if it has invaded any of the surrounding tissues. They also will look at the lymph nodes to see if there's any cancerous cells within the lymph nodes. And it will look for metastasis to see how far out this cancer has spread. So the primary tumor looking at for, again, it's on a TX for cannot be assessed all the way up to T4. T4 is the worst. Regional lymph nodes, it's on a 1 to 4 scale as well. And metastasis. So if it has metastasized, that's not a good thing. Okay. So an example, prostate cancer, stage 1, the cancer is small, it's only in the prostate. So we can go in and we can zap those cells that are abnormal and fix the problem. Stage 2, the cancer may be in both lobes of the prostate, but it's still confined to the prostate. Stage 3, it has spread to the neighboring locations, the lymph glands and the seminal vesicles. And stage 4, you now have prostate cancer that has broken off and metastasized to the bone. So you have prostate cancer cells in the bone, not bone cancer. Okay. Now, bone cancer can start within the bone and metastasize out, but it would be bone cancer to the brain that because it originally was bone cancer that has moved to the brain, not brain cancer. Okay. Okay. So we will stop here for right now and we will open this back up and start again in another video, part 2. Thanks, guys. Bye.